welcome to the Beverly Hills Plastic Surgery Podcast. I'm Dr. Jay Calvert, and I'm here with Dr. Millicent Ravello to talk to you about nasal trauma.
Nasal trauma, we see a lot of it. It's probably one of the most common things I get called for from the Cedars ER.
Oh, really?
Well, there's a whole politics thing about who gets called for what between ENT and plastics and surgery or what have you. But what it's sort of boiled down to over the past 2 years at Cedars-Sinai is that plastic surgeons get called for facial lacerations and for isolated nasal fractures. That's our specialty.
That's ridiculous.
I said it was political. We used to get the big facial traumas and the big face wax and the orbital floor fractures. Who does those now? I don't know. They're not very forthcoming about who they call, but typically it's OMFS. So the maxillofacial people.
Okay.
Yeah, I know.
We used to split it at Pittsburgh. It was a split between ENT, plastics, and OMFS. I mean, there's so much facial trauma. We just
That's
split
how
it
it was at County when we trained there.
Yeah.
But for whatever reason, some secret deals and handshakes were made, and so now they get all the facial trauma, and we get called for the nasal fractures. And it's really funny because sometimes I'll go see a patient with a nasal fracture, and the OMFS guys have already seen them for like their frontal sinus or their orbital floor. And I'm like, but you couldn't see them for the nasal fracture? But whatever, it's fine.
That's so wacky.
So needless to say, we see a lot of it.
And how you treat nasal trauma, this comes up for me all the time because, you know, there's a standard sort of approach, which is like, okay, you break your nose. Can you breathe? Is it deviated? Should we do a closed reduction and try to reduce the fracture, meaning put the bones back where they belong? Or should we just leave it and fix it down the road in 4 to 6 months?
Yeah, and there is sort of a set protocol in my mind for how I address them. So when I get a call about a nasal fracture that has just happened, there are a couple of things that I want to know. Number one, what part of the nose has been fractured? So it can be the nasal bones, which are the firm, rigid bones that sit at the top of the nose. And it could also involve the septum, which is the inner dividing cartilage between the two sides of the nose. And either one or both of those could be fractured. And so the first thing that you need to rule out is if there's any kind of internal bleeding in the septum, any kind of septal hematoma that needs to be drained immediately. That's a surgical emergency, because if you don't drain it, you can go on to actually lose the septum because it just gets eaten away.
And that's bad.
And that's bad. So that's the first question. Does the patient have a septal hematoma? It's very rare. You got to check for it. And if they don't, then you can go on to decide what your time course is for fixing this fracture. And to decide that, you sort of have to look at the patient and look at the imaging. Most of the patients, by the time they've called me, have already had a CT scan. Getting an x-ray for a nasal fracture, not really that helpful. So if you at all suspect it, typically they just go ahead and order a CT scan. And you look to see how displaced things are. Bones in the nose can be fractured, but can still be in perfect alignment. They haven't shifted. Sure. In that case, you're not going to do anything. You're going to watch it. Same thing with the septum. It might be fractured, but it might still be straight. So you watch it. But if there's any kind of deviation to the bones or to the septum, my inclination is to go ahead and fix it sooner rather than later. The exceptions being an older patient who might be on blood thinners, who might not care about how their nose looks afterwards. But if they're younger, they're healthy, and there's an obvious deformity, I would prefer to fix it within the first week to give them the best chance of healing that.
Yeah, and that's the thing. I mean, you probably have 14 days, maybe 3 weeks to do a closed
10 days
reduction.
is kind of my max.
I like to do it 14 days at the most, because then you're just re-breaking it.
You're re-breaking it because things have healed in their configurations. That's the whole reason to try and do it earlier. Now, you can't do it too early because you're going to have a lot of swelling right away. So unless you're getting it at like 3 hours, there's no point in doing it in the first 72 hours because there's so much swelling. You can't really see what's happening. Things are inflamed. So I like to give it a good 5 days to calm down, let the swelling come down, and then go in and do the reduction.
Yeah, I mean, that's what I like. I mean, I have caught them in the ER like in 3 hours sometimes, and I can just give them some local